right, good evening to everybody. Thank you for, after a long day at the clinic, you all gathered for a endowment lecture. I'm very happy to start off. Today is Dr. Kakarla Subba Rao's endowment lecture. We are happy to have the family. We'll take off. I'll request Dr. Merrill, campus director, to take us through about LVPEI and we'll begin from there. Thank you.
Good evening, everybody. So it's a pleasure to meet all of you here today, and welcome to the family of Dr. Kakarla Subba Rao, as well as to Dr. Prem Subramanian. Okay, so about LVP. So essentially, I think most of you know that this is an organization that started way back in 1987, and till date, we have over 317 centers. It's based on a pyramidal model where a majority of our centers are located at the base of the pyramid. They are the vision centers, and these are centers which are established in places which are remote rural areas where there's essentially no eye care available, and we have a vision technician who is trained after the 12th standard and he's able to do a good refraction, able to give glasses, able to identify a person who doesn't improve with those glasses and send it to the next level, which is our secondary center. So the secondary center, there are 25 of them now. A couple of more are under construction, 4 to be precise. And these will be opening in due course. But the secondary centers are manned by a couple of ophthalmologists, along with a staff of about 25 to 30. And what they are able to do at the secondary center is, treat common conditions, operate common conditions, essentially cataract and some very other minor procedures. But the beauty of the secondary center is that they are able to handle a majority of cases, and it deviates from the need or avoids the need for patients to travel to the tertiary center unless they have a complex problem. But in case they do have complex issues, then some of the faculty travel, not some, all actually are traveling to these secondary centers, and we give 12 days of our time in a year. At these centers, we do it in rotation, and we're able to handle several complex cases. Some of them have got registration for human organ transplantation, and we're even able to do corneal transplants at these centers, and that's something that's really remarkable. I'll be talking a little more about this effect of the fact that people are traveling to the centers. We have a tele-ophthalmology that's happening, so patients don't have to travel to see us, and I'll talk a little bit about that later. The tertiary centers, there are 4 of them located in Vijayawada, Visakhapatnam, Bhubaneswar, and Kadapa. And the Center of Excellence is here in Hyderabad. So all the, the academic work, the research work, the handling of all complex cases happens in the tertiary centers, with advocacy, innovation, and product development happening at the Center of Excellence here in Hyderabad. So essentially over the years, we have evolved into these 10 functional arms: patient care, eye banking, vision rehabilitation, education, capacity building, community eye care, eye health, research, technology innovation, product development, and advocacy, policy, and planning are the 10 functional arms with which we work right now. And this hexagonal picture that you see is because they're all closely interdigitated, and we all work together in order to ensure that all our patients may see. So a couple of highlights of the last, not 2025, but essentially 2024, was the fact that 4 of our centers actually factored in the top 20 eye hospitals in the country, with the main center in Hyderabad being number 2. In addition, we were awarded one of the 10 best NGOs of 2024 at the Global CSR and ESG Awards. One of the other things that has transpired over a little over a year ago was the fact that we crossed 50,000 transplants, and that is an amazing feat that was achieved by a single eye organization. In addition, the rehabilitation services that we have, and that's a unique USP of our organization, the fact that we're able to provide, beyond ophthalmology, we're able to provide rehabilitation services to those who have incurable blindness. Essentially, when we cannot treat them further, we send them to the rehabilitation services where they're able to get integrated into society, they're empowered, they're able to upskill, and they're able to get jobs. So this gives them significant amount of motivation, inspiration, and they're able to integrate well into the society because of what's being done in rehab. And we're very proud of the Institute for Vision Rehabilitation that got this Governor's Excellence Award last year. So the other new thing that was started almost a year ago now, or a little over that, was home care. So LVP at home, where we have, for those who are unable to come to us, essentially elderly individuals, vulnerable individuals, those who are in the wheelchair, those who have got other morbidities which doesn't allow them to visit the institute, we're able to visit them. We have all the facilities to do a complete eye checkup coupled with the teleophthalmology services, and they get care at their home. So this is the scorecard for 2024. Essentially, you can see that we've done almost 2.4 million patient services and over 38,000 rehabilitation services offered. What's heartening was that there's almost an equal, gender distribution of the patients that we have served over the years, and this has been noticed, across the network. So we have a very strong educational, forte, and we train all cadres of staff, right from the paramedical staff, the vision technicians that I talked about, the ophthalmic nursing assistants, the biomedical techs, the ophthalmologists who come in for super specialty training, optometrists, and the whole gamut, right from from all the staff that we require to help us in our day-to-day activities. And this is a very strong, service that we offer in terms of education. The other is technology and innovation, and there are several things that we've done new with the help of ideas that our members give us, either the ophthalmologists or the optometrists, and there are several innovations that have come up. One of which has, two of which actually are going into production. So we've been, working on these, and they're going to go into production and probably will be out for commercial, on the commercial aspect, very soon. So that one of them is the Bavis, I think, whose picture is not here, but that's a baby vision screener, and the other is a pupil N. So these are two products that will go out into the market very soon, and there are others in the pipeline which will follow suit. But one of the highlights, and that's been in the recent past, and I was talking about the teleophthalmology. So since we started this in 2020, this was spurred by the onset of COVID. The idea was that, since we could not reach our patients during COVID, we developed our indigenous software and started, having teleconsultations with our patients. So that kind of merged into, it was given over to a company called Wellsio, and it's now known as LVP Connect Care. So what we've done is we have a system where patients from the vision centers, from the secondary centers, or even from the tertiary centers who are unable to come to us for follow-ups because they stay so far away, we do a teleophthalmology consult with them. Now, we've done over 600,000 of these teleconsults. The economic impact to these patients has been a saving of 1.87 crores. If you had to calculate how much it would cost for them and an attendant to travel all the way, the loss of wages that would be expected for the individual who's traveling as well as to this particular patient. So 1.87 crores is a saving for these patients. But in addition to that, they have avoided traveling 240 million kilometers, equivalent to a reduction of 22,000 tons of carbon dioxide emissions, which are avoided by the fact that they have not traveled. And this is equivalent to planting a forest of 1.63 million trees. So that's been one amazing feat because of the teleconsults that we do. In addition to that, we have been working on our green initiative. Till date, we have generated 1 crore units of solar energy, which is an impact of saving of electricity of 10 crores. These are the centers where we have, installed solar in all our, across the network. This has resulted in a reduction of 8,050 tons of carbon dioxide emissions, which is the equivalent of planting 320,000 trees. So sustainability is something that we are very passionate about, and is something that we are striving to do, not just with respect to solar energy, teleconsultations, but also with respect to conservation of water, to recycling, and other aspects as well. Okay, so thank you all for your patient hearing, and we look forward to hearing your talk today, Dr. Prem. Thank you.
Very warm welcome, Dr. Subramanian, Sushruth Garu and Shobha Garu from Dr. Kakarla Subba Rao's family, and all our friends here, as well as those who have connected online. A very warm welcome to this beautiful evening session. I'm here to talk about Dr. Subba Rao. Can I have? Okay. So, this is the picture of Dr. Kakarla Subba Rao. He was an eminent bone radiologist because at that time, radiology had different specialties, and he was one of the eminent radiologists. And he has American Board of Examination of Radiology and worked as a special fellow at the radiology centers of New York as well as Baltimore. And immediately after his post graduation, he went and did a fellowship and then worked. And then he returned. He also worked in Osmania Medical College. These are the rare physicians, somewhat similar to Dr. Rao, who went there, got the best of the education, worked, and came back. And then he was also a faculty in the radiology departments of various medical institutes between 1970 and 86 in US. 1986 is where the foundation stone was laid to LV Prasad Institute. So he came back and he really rebuilt the Nizam's Institute of Medical Sciences to a level of premier institute. He was very much instrumental in making that institute one of the best in the country and also in the world. And he has many publications and he is outstanding repute in terms of radiology. And he also won the Padma Shri award then for his contribution to this particular field. But I just want to show something. What is the connection between Nizam's Institute as well as LV Prasad? 1987, we had our first patient, and in India, eye bank was not a part at all. Nobody will donate any eyes at that time. So Dr. Rao went to Dr. Subba Rao, and he asked about one small thing. Can we have a grief counselor who can counsel your patient's next of kin to donate the eyes? Just within a minute, he made a decision. Yes, your grief counselors, LV Prasad grief counselor, will be there at NIMS. He made the decision on the meeting itself. That was the genesis for Eye Bank Association of India. Now you are seeing many places and many people are kind of donating. And that was one catalyst which changed the eye banking of whole scenario in India. So that is why we could reach this milestone with that one decision. So Nizam's and LV Prasad is very closely knit on eye banking. We do share a lot of pathology as well as, we closely work with the pathologist. We closely work with the neurologist there. So this relationship continues, and he was very much instrumental in helping us. And he has one philosophy of life which we all can relate. I'll read those. I pass through this life only once. Let me do the maximum good to the largest number of people. This is very impactful, more so in 2025, what we are exactly seeing around the world. Whatever that small thing we can do, I think it's a great one. So I'm really happy that Dr. Prem Subramanian is here. You can see he's flying from Denver to Hong Kong to Singapore, Singapore to India, and then he is returning. So almost 360 degrees travel, and he made this specially for this trip. Thank you very much, and I would like to invite Divya to give an introduction of Dr. Prem Subramanian. Thank you.
It's my privilege to introduce our guest speaker for today, Dr. Prem Subramanian. He is a Clifford R. and Janice and Merrill Endowed Chair in Ophthalmology. He is a professor of Ophthalmology, Neurology, and Neurosurgery, and also the Vice Chair for Academic Affairs at the Sue Anschutz-Rodgers University of Colorado Eye Center. He is also an adjunct professor of surgery at the Uniformed Services University of the Health Sciences. So apart from an MD degree, he also has a PhD in molecular and human genetics at Baylor College of Medicine in Houston. He was one of the founding members of the medical staff of the Marcus Institute for Brain Health as well, where they dealt with traumatic brain injuries primarily. He is a very avid academician and a researcher. He is the current president and a member of the board of directors of the North American Neuro-Ophthalmology Society. He's also the vice chair and a member of the board of trustees of the Council of American Academy of Ophthalmology. He has more than 230 peer-reviewed publications. His focus mainly is on progressive thyroid eye disease, on intracranial pressure and the diseases that are concerned with that, and also the neurovisual dysfunction following traumatic brain injuries. So apart from all this, he's also an avid orchestral and chamber French horn player, and he's also a skier and a cyclist. Today, we are going to hear him speak to us on a very interesting topic, Spaceflight-Associated Neuro-Ocular Syndrome. Now, this is a very different topic, and there are very few experts across the globe that are actually working on this, and we are privileged to have one such person with us, Dr. Prem Subramanian. I welcome you to this.
Thank you. How many of you wanted to be an astronaut as a child? How many of you still want to be astronauts? They're looking for adults, and we're looking for doctors who want to go into space because, as you will see, there are certain problems that happen to us when we go into a microgravity environment because we were not designed to be in the absence of gravity. These financial disclosures are not relevant to what I'll speak about today, although I will show you some work on a pharmaceutical that I'm developing to try to lower intracranial pressure. It's not been that long since humans have been going into space. We know that in 1961 was the first time a human orbited the Earth, Yuri Gagarin, and then you can see the subsequent space missions since then. Humans started staying in space for an extended period of time, and I'll define long-duration space flight as being anything longer than 3 months, even in the 1970s with Skylab, which was only up for 2 years. The longest continuous space flight is actually just over a year, held by a Russian cosmonaut that was completed 30 years ago. And in fact, the longest US astronaut has been in space just for slightly longer than a year at 371 days. And just recently, a Russian cosmonaut had a cumulative exposure to space of 1,110 days. So that is not quite 3 years. And if you think about how long it would take to do a long-duration space mission, the things that people talk about like going to Mars, that would take optimistically 10 months to get there, spend some period of time, and then 10 to 12 months to get back. So a lot of exposure to a microgravity environment. And what I will go through today are observations that have been made about what happens to our vision that may or may not be related to what happens in other parts of the body. So if we look at subjective changes in vision, they have been noted since the beginning of spaceflight. The Apollo astronauts had blurred near vision. Now remember, the Apollo astronauts by and large were pilots, Air Force pilots who then became astronauts. They were accomplished pilots, so they were usually at least in their 40s, and they were all men and they were all fit and healthy. So why did they start having blurred near vision? It was thought that this was a kind of induced presbyopia. And subsequently, as I'll show you, we learned that they get thickening of their choroid, moving the retina anteriorly. And so the space agency developed these space anticipation glasses. Some of you may have remembered when these were being sold to the public as super focus glasses. And that little slider there allows the astronaut to increase or decrease convexity of the lens to increase that near focusing power. And here you see astronaut Alvin Drews on the space shuttle eating a prepackaged spaceflight meal and wearing his super focus glasses so he can see them. 50% of long-duration astronauts also experience some degree of subjective blur. You can imagine if you are an astronaut and your vision starts to get blurred, you would think that's rather concerning, right? This is a mission-critical skill. And it does not always resolve. Some of them have a persistent hyperopic shift, as I will show you. And then, so that led to routine eye exams being done on astronauts before going to space and upon their return. And then in 2005, it was noted that an astronaut had disc edema along with cotton wool spots in the retina. So just 21 years ago, we began to notice that there were particular changes that could happen in astronauts who were in space for a long duration of time. Now, to date, there have been 72 missions to the International Space Station. That's not a lot. And some of those people are return visitors to the space station. And so the number of individuals who we have to study on this condition remains relatively low. But if we are to become a spacefaring world, as some would like us to become, maybe we create such problems on this planet that we need to leave and we need to go somewhere else. Planning for these sorts of things and understanding, can humans even potentially do this, is a critical focus, and it also will help us to understand more about normal human physiology here in the terrestrial environment. So you'll hear me refer to things like zero-G, micro-G as corresponding to spaceflight exposure, and you'll hear me refer to 1G or terrestrial environment as what we are used to experiencing on a daily basis. So again, we've been studying this for about 20 years. There have been representatives coming from NASA, SpaceX, Russia, the EU, Japan, but there's been no uniform pre- and post-flight testing protocol. And politics are always changing, but one constant is that people don't trust each other, and that the Russians never shared data with the rest of the world as to what was happening with their cosmonauts. To this date, they still deny that SANS actually exists and that their cosmonauts experience these problems. We know that that is patently false. So that's another barrier to studying this particular problem. But as I mentioned, 2005 was the first observation of potential changes, and in 2011, a series of astronauts was studied by a number of individuals within and outside of NASA, and this was led by Tom Mader, who is also a former U.S. Army ophthalmologist who had a long-standing interest in high-altitude changes that occur in the eye. And interestingly, some of the changes I'll show you have also been seen with extended exposure to high altitude. Whether hypoxia has something to do with this or not is something that we're still trying to understand. But in these 7 astronauts on whom we reported in 2011, 5 out of 7 had unilateral or bilateral disc swelling. 1 of them had choroidal folds, and there was some posterior globe flattening and potential choroidal thickening. So this image from that paper, the large arrow in the center shows a radiographic representation of papilledema that you saw on the previous photographs as well. The small arrows are pointing to a little bit of posterior globe flattening. Both of these signs are something that many of you have seen reported on or seen yourself in images of patients with elevated intracranial pressure. And so because of these findings, in fact, this condition was named VIIP or VIP, Vision Impairment Intracranial Pressure Syndrome. I'll show you why we since abandoned that term and switched to the more generic Spaceflight-Associated Neuro-Ocular Syndrome. But again, it was very curious that there were these findings that we see in patients with elevated ICP, like a tortuous optic nerve on this sagittal MRI of the orbit, where the vertical arrow is pointing to a kinking of the optic nerve, a vertical displacement. The short arrows are pointing to the globe flattening again, and the other upward-facing arrow is actually pointing to some changes in the CSF space surrounding the retrobulbar optic nerve. All of these things being potential signs of elevated intracranial pressure, and I spoke already about the implications that these kinds of changes have for people who might be undergoing long-duration spaceflight. And in fact, NASA has identified potential vision problems as being the number 2 risk to health hazard for going into long-duration spaceflight. Anyone have an idea what the number 1 risk would be? It's radiation exposure, because when you go outside of our Earth's atmosphere, you're exposed to deep space radiation that we just have no idea how that is going to affect the human body, penetrating high energy particles and other exposures that just simply were never encountered on Earth. Let's talk a little bit about the pathophysiology of what happens to a body when you go into space, and then why that might result in the characteristic abnormalities that we are seeing in SANS. I mentioned that there are a number of different changes that have been observed in association with some of them with short duration spaceflight, but other more specific to long duration spaceflight. So if you look going from the top and going in a clockwise direction, you can see that there are these radial choroidal folds that have been observed in the top two images. The optic disc edema, of course, is something that has only been seen with long duration spaceflight, has not been seen on shorter missions. This increased optic nerve sheath diameter, again, potentially indicating an accumulation of cerebrospinal fluid behind the eye, posterior globe flattening, but an unusual characteristic. Again, if we look over here, there we go, at this image right here, we can see that there are cotton wool spots which are not a typical feature of elevated intracranial pressure and do speak to a potential vascular problem that might be going on in our patients who have this condition. And then finally, I already talked about the blurred vision and the hyperophic shift that might occur. When you go into a microgravity environment, you have a cephalad fluid shift because gravity is no longer pulling our fluids down towards our legs. And so this is somewhat akin to what happens when you are supine, although it's not quite the same. And so this is a photograph at 1G of astronaut Leroy Chow and of astronaut physician Michael Barat. Good-looking men, right? Normal-looking faces. This is before they go into the microgravity environment. Once they go up there, they now have this much fuller, plethoric appearance to their faces because of that cephalad fluid shift. And so you can appreciate that if fluid is accumulating in the soft tissues of the head, then perhaps fluid is accumulating intracranially as well. And certainly that was one of the concerns that was raised. You can see that there's normally the gravitational pull, that you have a normal hydrostatic gradient where the fluid pressures are greatest down at the legs. If we go to a zero gravity environment, of course, everything then just equalizes and you get the facial puffiness and these so-called bird legs, as the legs shrink because of the fluid going upward. And if we have cerebral venous congestion, that's going to be exacerbated by this condition, and we can replicate it not really by a 1G position in the being supine, but rather a 6-degree head-down tilt has been created as a model of microgravity exposure. That's 6-degree head-down tilt for 23 hours a day that healthy human volunteers will do, and they do this for weeks on end in order to help us try to recreate some of the findings that we see in SANS. Because again, we have a limited number of astronauts who have ever been exposed to microgravity. And for those of you who do human subject research, another thing you have to recognize is that it could be very easy to identify who these astronauts are being studied in these papers that we are publishing. And so we have to be careful about grouping these astronauts together. And they, of course, have the right to opt out of certain research projects. And so all of these things are limiting, and we have to be creative, and we have to use a lot of theoretical models or theoretical calculations to try to figure out what is happening. So I mentioned before, you saw how the fluid shifts toward the head. There are key brain areas potentially affected by fluid shift. And so you can see that fluid reabsorption into arachnoid granulations may be impaired because of the increased cerebral venous pressure. So there's a change in that gradient. You could have interstitial fluid that develops within the brain itself. CSF production might be changed in the microgravity environment. But essentially, the skull is a box, right? You have a fixed volume, and so if there is more fluid into that fixed volume, it is going to create increased pressure, and particularly if the superior sagittal sinus pressure, as shown there in the Davson's equation, if that is increased, then intracranial pressure has to increase as a result. So there are a number of ways in which abnormalities could occur. Now, some short duration mouse studies that were done on the space shuttle showed that there is an adaptation where in the middle you can see that there is a decrease in the choroid plexus, in the villi that produce the cerebrospinal fluid, and that when those mice return to a terrestrial environment, that they repopulate. But that change doesn't appear to be enough to decrease cerebrospinal fluid production enough to prevent elevated intracranial pressure. Another confounder is all of that cephalad fluid shift creates a decrease in lymphatic outflow as well. We don't think a lot about lymphatic outflow as ophthalmologists. And even neurologists don't necessarily think about the fact that maybe 40% of cerebrospinal fluid drains through lymphatics that invest your cranial nerves. And even more importantly, as there is a fluid shift or pressure shift, or an increase in intracranial pressure, then that lymphatic drainage pathway becomes even more critical. So if you have elevated intracranial pressure and you have increased venous sinus obstruction to venous sinus outflow, that is preferentially blocking the pathway that the body normally uses to decrease the intracranial pressure. So you're getting hit from both sides. And in particular, on the right side here is a picture of the olfactory mucosa, which we'll come back to as a potential route for outflow of CSF along those olfactory nerves that go directly through the cribriform plate into the nose and could allow CSF to exit into the nasal passages. Another potential contributor is carbon dioxide levels. We on Earth have a fairly stable carbon dioxide level, more or less controlled by respiration by plants and our own respiration. And we find that in a spaceflight environment, if you don't exquisitely scrub the CO2 out of the air, that it can go up to 10 times higher than the levels in a normal terrestrial environment. And we know from studies that increased CO2 also increases intracranial pressure. We know that in our patients with sleep apnea who have CO2 retention because of their apnea, that their intracranial pressure goes up. So there are, you can see a lot of different factors that could be leading to abnormalities that can result in elevated intracranial pressure, potential for optic disc edema and other brain dysfunction, which I don't have time to talk about today. And then, as though that weren't bad enough, if you already have a little bit of pressure shift to the right, that your ICP is already going up because of this cephalad fluid shift, and then you add in a little bit of increased CO2 in the inspired air, that puts you at the steep aspect of this curve where you're then any little change is going to markedly increase your intracranial pressure. So I've told you a lot of factors that could go into raising intracranial pressure. I started out by saying that we're not sure that intracranial pressure is a sole driver of this problem, but there's clearly evidence that it's part of the problem. And to understand how much it might be playing a role, wouldn't it be nice to be able to assess intracranial pressure in flight, right? I'm standing here telling you all these theoretical things. Can we really assess it in flight? Well, we looked first at looking at some work that we did a number of years ago to see if spontaneous venous pulsations might be a way of assessing intracranial pressure, or at least a rise in intracranial pressure, because we know that they should be present in people of astronaut ages, they can be evaluated pre-flight, and then you could potentially look for their disappearance in flight. And we showed a number of years ago that the majority of people, again, of this age, have spontaneous venous pulsations. They tend to go away with greater age, but they're also IOP dependent. And there are IOP changes that occur in spaceflight, as I'll come to, that are confounders because, in this work that we published just on normal people on a terrestrial environment, we found that intraocular pulse pressure was a predictor of the presence or absence of spontaneous venous pulsations. We don't know what's happening with intraocular pulse pressure in a spaceflight environment. And so that, again, is a limiting factor for what we might be able to study. How many of you have used ultrasound to look for optic nerve sheath distension in patients where you suspected papilledema? I'm sure some of you have. This is a somewhat standard clinical technique with B-scan ultrasound. The space station has a medical ultrasound on board because the astronauts need to be able to diagnose problems like abdominal abnormalities. They eat a very high salt diet as being necessary in a spaceflight environment, and so they are at risk for kidney stones. So they have to be skilled in doing ultrasound on each other. And here you see an astronaut performing ultrasound on the eye to try to get an image that you see there on the right of the retrobulbar optic nerve sheath. So could we use that as a way of seeing what's happening with intracranial pressure? Well, some initial studies were promising, suggesting that if you compare the individuals who developed SANS, remember, not everyone who goes into space develops SANS findings. If you compare those who didn't in blue and those who did in red, there seemed to be a relatively strong correlation between the retrobulbar optic nerve sheath diameter and the incidence of having optic disc edema or other findings. So why don't we just use this? Well, this is an example of findings in orbit of the optic nerve sheath enhancement. The green shows the change, the widening of the optic nerve sheath from the pre-flight, which is in purple. The primary problem that we observed is that the optic nerve sheath exhibits hysteresis, meaning if you stretch it beyond a certain point, it does not stretch back or does not shrink back. And many of the astronauts exhibited that finding, that once it stretched to a certain point, it was no longer representative of what the intracranial pressure was. It didn't go back to normal necessarily when they returned to a terrestrial environment. And so also, many astronauts continue to be former pilots. Pilots who pull high G turns will also drive CSF temporarily into their optic nerve sheaths, and on average they have a larger optic nerve sheath diameter. So even though we measured some changes that seem to be potentially indicative of prediction of developing SANS or not, ultimately this has not been a successful methodology. Now, why don't we just do lumbar puncture in space? These astronauts are trained. We could train them to do lumbar punctures. The space station is a closed environment. All the bacteria that travel on our bodies into space stay there and colonize the space station and are never cleaned out. I would not want a lumbar puncture done on the International Space Station for that reason. It's just impossible to do things in a truly sterile manner that way. Also, we don't know the physics of it. Would it be reproducible? Would a manometer actually show in a zero-G environment the same ICP elevation that we measure in a terrestrial environment? There are some patients who have implanted intracranial reservoirs because they've had brain cancer and they get cancer chemotherapy through that Ommaya reservoir, as it's called. And you can tap that reservoir and potentially measure the pressure directly. But again, outfitting an astronaut with an intracranial reservoir like that is a bit of a dicey proposition. There is another way to potentially indirectly measure intracranial pressure that my colleagues and I have been working on, and this is a work of Ali Anderson-Heyman, who is a professor of aerospace engineering at CU in Boulder, and we have this lovely collaboration between our departments. And she has done work on something called distortion product otoacoustic emissions. You probably didn't realize it, but in addition to receiving sound, your cochlea puts out sound spontaneously. You don't hear it, of course, but it's constantly emitting sound. And those sounds that it emits are dependent in part on intracranial pressure because of its exposure to the intracranial space. And so by recording these emissions, you can indirectly assess what's happening with intracranial pressure. The problem is it's indirect. It is not a direct measurement of actual pressure, and so there's not a clear way to correlate those changes with ICP in a given individual. I don't know if any of you have seen this device. It's commercially available in the US and other countries. It's a Lithuanian device that does directly measure intracranial pressure, but in a non-invasive way. And without going too much into detail, you can see from the figure on the right that it applies pressure to the orbit. And it does that in a slow escalating manner and uses colored Doppler ultrasound on the intracranial portion of the ophthalmic artery and on the intraorbital portion of the ophthalmic artery. And when it gets them equalized, when the flow characteristics are equalized between the intracranial segment and the intraorbital segment, that tells you that the orbital pressure being applied has to be the same as the intracranial pressure. It takes about 20 minutes for a skilled operator to do this. We could send this up potentially onto the space station, but those astronauts are already scheduled 24/7 doing various tasks, some scientific, some mission-oriented. And to take 20 minutes out of however frequently and to do this, and you have to do it multiple times in order to get accurate series of readings, I don't think it's very practical. Finally, there is a wireless implanted model. We have at least one European in our audience, and this is available in the EU and is used routinely to measure intracranial pressure in people with problems like seizure or ICP disorders. It's not FDA approved, and so we can't use it in US astronauts, and we don't have that telemetry box to probe the device when it's in space. But some astronauts have actually volunteered to have this intracranial monitor placed. I'll just briefly mention lumbar punctures were done in 7 astronauts after returning from space. The results are completely inconclusive there, as you can see, because it's all over the place and didn't correlate very well with their degree of severity of their SANS. So then we realized that some astronauts had persistent optic disc swelling. In this report from 2017, we profiled a 45-year-old astronaut, normal pre-flight eye exam, that's his pre-flight optic disc picture. He was slightly myopic. His distance vision improved, probably because of a slight hyperopic shift. And you can appreciate in the disc photo on the left now, this was in flight, he had optic disc swelling. Mild, but present. 4 days after returning, that's what R+4 means, he still has optic disc swelling, and you can see that on a sagittal MRI that is done, he has posterior globe flattening on the right, a little bit more than the left. His left optic nerve was not particularly swollen, and there is some slight dilation of the retrobulbar optic nerve sheath and the fluid around it. This is a photograph of his fundus photo, again, some months later, showing persistent disc swelling, and the arrow points to the swelling there, but the other arrow now is pointing to another curious finding, which was a white-centered hemorrhage in the retina. We still don't know exactly what is causing this distant from the optic disc. We have a suspicion that this could be cosmic radiation passing through the eye and causing temporary damage, but we just really don't know what that is, and we have no idea if cosmic radiation is playing a part in the development of SANS. Why would optic disc swelling persist for months after returning from spaceflight? Everything should normalize when you're back in a terrestrial environment. We think sometimes of the optic nerve sheath as being like a drinking straw with the optic nerve within it. But it is not. It has a lot of trabeculations, as shown here in this paper that we published several years ago. And you can see that, especially in the intraorbital segment, there are these tight septi right here. And the canalicular portion, this is a little out of proportion because the optic nerve comprises a much greater portion of the volume within the intracanalicular part of the optic nerve and is a potential barrier to the free flow of fluid into the orbital segment and out of the orbital segment. We make this presumption that there is free flow of fluid, and here you see 3 cadaver cross-sections of those same parts of the optic nerve, and you can appreciate especially the canalicular part on the right has a very thin area of cerebrospinal fluid and a number of septations that could alter flow through there. And we know that there's this theory of a translaminar pressure gradient as being the reason for papilledema, that on the left we see how there's a normal translaminar pressure gradient of about 5 millimeters of mercury. As ICP increases, it puts pressure on the back of the globe, leads to axoplasmic stasis, venous outflow obstruction. And this same thing has been demonstrated here on these cadaveric models. I'll skip over that in the interest of time. But I just want to bring it back to, just quickly, a terrestrial model or terrestrial patient that I think helps us to understand these findings. This was a 32-year-old woman who was previously healthy. She awoke, she was found unconscious at home. She was brought to the emergency department, had altered level of consciousness, again, had an MRI scan that showed a very large tumor. So that's the reason for her presentation. You can imagine that a tumor of that size on this flare image showing that white area that is very indicative of a lot of brain edema might cause papilledema. And indeed, she had bilateral papilledema. Our neurosurgeons, as they do, did a wonderful job removing that tumor, relieving this obstructive hydrocephalus that she had, and restoring normal ventricular architecture. So you would expect her papilledema to go away, wouldn't you? And it should go away rather quickly. But like that astronaut who returned and had persistent optic disc edema, this patient 1 month later still had persistent bilateral optic disc edema, indicating sequestration of CSF, a pushing of the CSF into her optic nerve sheaths that could then not escape. And only by doing an optic nerve sheath fenestration was I able to get this papilledema to resolve within a few days. But she was starting to lose vision from this problem, and that's the concern we have with astronauts, that this pressure being pushed into that periocular compartment, into that optic nerve sheath, could result in actual vision loss. Why is it relevant? There is a different AREDS than what we are used to in ophthalmology. This ARED is the Advanced Resistive Exercise Device. And this is required for the astronauts to use 90 minutes per day to avoid losing bone density. Because if you're not working against gravity, your muscles and your bones start to atrophy. So they have to do this resistance exercise, and you can see they're not supposed to hold their breath, but unfortunately our astronaut there is showing very poor form and doing, these Valsalva maneuvers as he is doing these exercises. And so that could be another factor. We can't stop them from doing that. So how are we going to monitor them? And then I'll finish with talking about how we might try to prevent it. We now have a spectralis OCT on the International Space Station. That was a result of 4 of us as neuro-ophthalmic consultants to NASA saying we need to understand this better. To give you an idea of what a major decision that was, it cost $50,000 US per kilogram to lift something into space. So weigh your spectralis sometime and calculate how much money it costs to put that thing up there. And so we started with some basic studies of looking at RNFL thickness from pre to post flight, and not surprisingly, we were seeing this optic disc edema and we were seeing RNFL thickening. And initially we came up with some classifications for the severity of SANS based on the severity of the RNFL thickening that was being seen. But RNFL thickening was not always returning to baseline when these astronauts returned to the terrestrial environment, and this also didn't necessarily correspond to any progression of changes over time. So again, although there was a significant association with higher grades of SANS and this classification system, it sort of fell by the wayside. And so we had already had a fundus camera, and so serial fundus photos were being taken, and you can see in this astronaut going from pre-flight to 30 days to 90 days that there is a serial increase in optic disc swelling that was not present there at baseline, and it's continuing to worsen by 150 days, 5 months in space, and by 7 months, I think it, even to a fairly novice observer, you can appreciate that there is disc swelling that is progressive. And OCT allows us now to quantify these abnormalities and to quantify the change. So for example, we start with, this is a reading from an actual astronaut who had a baseline level of 114, 111, and now you can see the global thickness has gone up to 127 and 120 microns, and this is at 30 days. So already there is significant change that can be tracked quantitatively by the OCT. OCT also allows us to appreciate choroidal folds of a magnitude, again, that we don't really see in terrestrial elevated intracranial pressure disorders. And so the OCT was really critical, not only to quantitatively following optic disc swelling, but helping us to understand more about what's going on with the eye as a whole. And so we presumed that these choroidal folds were coming from a choroidal thickening, an increase in choroidal blood flow from the microgravity environment and the cephalad fluid shift. And we could take these line scans through the macula, as you can see, and also take serial imaging. Again, this is from that individual I showed you previously, his optic disc photos. This is showing you the serial cross-sectional OCTs through the optic disc. And remember, he had persistent, what we called papilledema. Maybe it's not purely pressure-related. But for those of you with a little more neuro-ophthalmic knowledge out there, I want to point out to you that the Brooks membrane opening in both eyes has a posterior bowing away from the vitreous, which we don't see. In other words, anterior bowing is more characteristic of papilledema from elevated intracranial pressure, and we are not seeing that in this astronaut who had persistent disc swelling for many months after returning from spaceflight. And in fact, we looked at changes in the Brooks membrane opening position, looking for an anterior or posterior displacement of the Brooks membrane opening height. And we were not seeing that there was a consistent displacement one way or the other. The average was actually going a little more posterior. We also observed that you can more reliably measure the total retinal thickness rather than just the RNFL thickness at a distance of 250 microns in a circle from the optic nerve. And this has been proposed by a different research group that is studying SANS as a way of describing the disease. I would not put it forward as the definition of SANS, but I would like you, by looking at these graphs, to just appreciate that if you pick that point 250 microns away from the from the Brooks membrane opening, and if you measure changes from pre to post flight, you can very accurately assess the changes in total retinal thickening. There's not a lot of distribution in either one of those. There's not a lot of variability. So this is a metric that can be easily obtained, reproducibly obtained, and potentially used as a way of tracking what happens. Taking all of these measures together, what does it tell us about the role of intracranial pressure and what's happening in SANS? If you look at just features, qualitative features, choroidal folds, inner retinal folds, and peripapillary wrinkles were seen in ISS astronauts. But those are not common features in IIH. IIH has much greater likelihood of peripapillary wrinkles, which were less frequently seen in astronauts, for example. And inner retinal folds, again, characteristic in IIH, not really seen in SANS. And then if we look at progression of macular folds over time, these choroidal folds in the ISS crew members, you can see that there is a persistent increase. There's no flattening. There's no, as far as we can tell, they have not reached a stable point at any time during their space flight. And so you can imagine it. So far, there's not been any visual distortion from this, but I would not want slowly worsening macular choroidal folds happening to me in a spaceflight environment where my vision is critical to conducting a mission. And then finally, we can see that if you compare, I showed you that Brooks membrane opening deflection. If you compare what happens in IIH, which is on the top, and in SANS, which is the lower graph, in IIH, almost uniformly, there's an anterior displacement of the Brooks membrane opening, whether it's severe or mild. In SANS, the average is 0, right? Some go forward, but some are going backwards, and even advanced SANS, worse thickening, led to a mishmash of findings. And this has led to the idea that it is really orbital pressure, periocular orbital pressure increase, along with the changes in the pressure within the optic nerve sheath that are responsible for SANS. And so I'm going to finish by talking to you about, I'm going to skip over this, about what we're going to do about this. How are we going to try to address it? Because there are some problems in life that you can't fully understand before you try to fix them. And so some approaches that have been taken are to use lower body negative pressure. So a vacuum trousers, essentially, these were created by the Russians called the Chibis suit, and it just sucks fluid back down into your legs. A pretty easy way, potentially, to negate some of the cephalad fluid shift and potentially lower intracranial pressure. Again, it sort of limits what the astronaut can do while they're wearing this device, and so you have to weigh the pluses and minuses of wearing a suit like that, but sucking blood down into the lower body. You can use a thigh cuff, as shown here, that compresses the deep veins of the leg and allows fluid to be trapped so that it does not get returned into the abdomen and thorax. You can imagine you have to be careful with these devices not to cut off circulation to the leg, and so a little bit of danger associated with things like that. There are efforts to potentially alter intraocular pressure. There's a device that was invented by John Berdahl to try to treat glaucoma with goggles that would alter the intraocular pressure, lowering it by creating a slight vacuum around the eyes during sleep, potentially by reversing that and slightly increasing the intraocular pressure, not to give someone glaucoma, but to change that translaminar pressure gradient that I showed you so that it is more equal, so that there is a lesser likelihood of optic disc swelling occurring. That is a potential way of altering this, and this is a device that's now commercially available. We are working on altering lymphatic CSF outflow, and I'll skip over these slides here and just show you to finish up some work that we have done and that we have in phase 1 development right now. Prostaglandin analogs increase arterial contractility but also increase lymphatic outflow. And some of you may have observed clinically that patients who have had a radical neck dissection will have a poorer response to prostaglandin analogs to lower their intraocular pressure, potentially because lymphatic outflow has been taken along with those other vessels in the radical neck dissection. And so we had a hypothesis that various ocular medications, prostaglandin analogs, could potentially lower intracranial pressure. So we studied mice. Again, I'm going to skip over the details, but essentially I had awake mice inhale small droplets of prostaglandin analogs to coat their nasal mucosa, and then injected a tracer intraventricularly, recovered that tracer from their nasal mucosa 1 hour later, and looked to see if we could enhance it with the use of a prostaglandin analog compared to controls. It was tolerated well, even over several days. You can see here that a few analogs were no better than control, which is the white bar on the right, but when we used latanoprost, which are the bars to the far right here, there was a significantly increased recovery of that tracer from the ventricles. It markedly increased CSF outflow. Another way to increase CSF outflow potentially is through the use of GLP-1 agonists. You can't talk in 2026 without talking about GLP-1 agonists. And so some combination perhaps of GLP-1 agonists and prostaglandin analogs could provide a safe way for us to address the intracranial pressure, the cephalad fluid shift, and at least take that aspect of SANS out of the equation. So at this point, I think I have left you with the idea, and I've left you probably with more questions than answers about SANS, what causes it, and what we might do to treat it. But that's the nature of this condition. It was only discovered 20 years ago. It has only been studied in a bit over 100 people in a true microgravity environment. Experiments are being done on people in head-down position. I could talk for another 2 hours about all of the things that are being done to try to study this disorder. But if some of you out there have ideas that have been triggered by this review of what we see, what we understand, and what we don't, I encourage you to take that forward, to look into the physiology of this, the pathophysiology, and potential changes that might help us both to understand disease better in our human subjects and to protect us as we venture into a spaceflight environment. So it's my real honor to have given this oration to you today for the Kakarla Subba Rao Endowment Lecture, and I thank you for your attention.
very much for that fantastic talk, Dr. Prem Subramanian. We now have the presentation of the plaque. I request the family of Dr. Kakarla Subba Rao, Mr. Shushruth Garu and Mrs. Shobha Garu to please come on the dais. I request our Vice Chair, Dr. Rajiv Reddy, our Director, Dr. Merrill Fernandez, on the stage. Dr. Prem Subramanian. I'd like to thank the family of Dr. Kakarla Subba Rao for being present here today. Mr. Shushruth Garu, Mrs. Shobha Garu, thank you very much. Deeply grateful to Dr. Prem Subramanian for giving us such a wonderful talk on this particular condition. I'm sure this is very new for most of us, and I'm sure that then we got to know all the changes that can happen in the eye when you go to space. So I'm not sure how many of you want to become astronauts now, but yeah, thank you so much. I'd like to thank the entire organization team, Mr. Mahavir, Dr. Virender Sachdeva, Dr. Ramesh Kekunyan, all the staff, faculty for organizing this event. I'd also like to thank our communication team, our audiovisual team, our transport, housekeeping team for making all the arrangements as they always do whenever we have such events. So thank you very much for being present and making this a success. Thank you.